طبعا في الاول انا بحب اشكر شركه مالتي كير انها اتاحت لي الفرصه دي ان انا اتقابل معاكم في ظل طبعا ظروف الحظر اللي احنا موجودين فيها، وان احنا ما نقدرش نتقابل وجها لوجه عشان ظروف الوباء الكورونا اللي موجود حاليا. طبعا First of all, I would like to thank Multicare Pharmaceutical Company for giving me the chance to meet you and talk about fractures of the distal femur. I'm going to speak about the X-fix or external fixation. This is very important topic. You know, some cases you need to do external fixation. As you see here, we have in the first slide, you have comminuted fractures, you have open fractures, we have a bone gap, we have elderly patients. Sometimes the early patients, especially above 75, they have osteoporotic bones. So in many circumstances, perhaps you need to do something else, not only internal fixation. You know, we have two methods of fixation of these fractures: internal fixation or external fixation. And sometimes you can combine them. It's a real, sometimes people think it's a real fight, but actually you can combine them together to treat the patients. The basic principles. We have these basic principles. You should have anatomic reductions for the articular fractures. For articular fractures, you need anatomic reduction, not acceptable reduction. There's a big difference between anatomic reduction and acceptable reduction. So in such cases, you should have anatomic reduction of the articular fragments. You need stable fixation, whatever the type of fixation. And thirdly, you need early mobilization. The methods of reduction, we have open reduction, semi-invasive with a small incision, and non-invasive without incision. Anyhow, we've learned that in the three circumstances, after open reduction, semi-invasive reduction, non-invasive, you need internal fixation. So, internal fixation is the winner in all three circumstances. So in all the cases, you have to do internal fixation. Perhaps this was the first internal fixation or intra-articular internal fixation in history with this nail, prosthetic pin, and 3,000-old mummy by the pharaohs, as you see. The classification. The commonly used classification is Muller AO classification, type A, B, and C. A, an extra-articular fracture. A1, A2, A3, depends upon the three, you have comminuted extra-articular fracture. Type B, you have partial articular. Partial articular, B1, B2, B3. B3, you have half a fracture, or a fracture sagittal plane, taking the posterior femoral condyles. C, complete articular. You see, you have complete Y-shaped or comminuted, severely comminuted intra-articular and extra-articular fractures. Again, this is the classification. A, extra-articular, B, partially articular, C, intra-articular and extra-articular fractures, which may end up with C3, comminuted intra-articular and extra-articular fracture. If you look to this table, taken from a paper from a hospital about the distal femoral fracture, 260 or something femoral fractures treated in this tertiary referral center hospital in England. And you see the lines of treatment: non-operative treatment, plating, nailing, arthroplasty, or others. You see, no one speaks about external fixation. They didn't, it's not counted, the external fixation. Why the people ignore the external fixation in treatment of this type of fractures? And in this paper, they spoke about the role of external fixation as a temporary fixation device, just as a temporary, كأنه شيء مؤقت فقط لا غير. محدش بيتكلم عن الاكسترنال فيكسيشن كنوع من انواع التريتمنت الدائم، لا، هو برضو از مرحله عشان تقدر تعمل internal fixation بعدها. So in this paper, they speak about temporary X-fix as a temporary fixation device in polytraumatized patients, patients with massive soft tissue damage, open fractures, infection, situations with logistics or some problems. It's not only that. They always speak about complications of X-fix as a definitive treatment. هما بيحاولوا يتجنبوا الاكسترنال فيكسيشن كعلاج. ليه؟ حاجة تموت من الضحك طبعا زي they say that external fixation can cause osteomyelitis in spite of we use external fixation or Lazarov or circular fixator or hexapodal or whatever in cases of osteomyelitis. Pin-track infection. Pin-track infection is something no problem in most of the cases. Septic arthritis. You have to avoid the joint. Loss of reduction. I don't know how you're going to lose the reduction. If you do have good fixation, delayed union or non-union. Unfortunately, this is very strange. Limited knee motion through arthropfibrosis. These were the reported complications. People reported these complications to stop the people from using external fixation as a definitive treatment. مش كده بس دول بيحذروا من استخدام الاكسترنال فيكسيشن كتريتمنت نهائي. حاجة في منتهى الغرابة. So internal fixation had been described as a Frankenstein of orthopedics. Panic if you use external fixation. This is the real picture in the English literature about external fixation. Frankenstein. حاجة تخوف. يخوفوه كلهم من استعمال external fixation. So actually they put you inside the box. It looks like every problem needs only one solution, internal fixation. Therefore, finding more than one possible solution is a waste of time. انت بتضيع وقتك. لازم كل العيين تعمل لهم internal fixation. كلهم بينصحوا بكده. كل الانجليش literature, all the English literature speaks about internal fixation. All the arguments about whether you do retrograde nailing or locking a plate, whether you do close reduction, open reduction, or semi-invasive, but finally you have to do internal fixation. So actually it's thinking inside the box. External fixation, do they have the same function? The second problem we meet in the English literature when they speak about X-fix, they group all the external fixators together. So do they have the same function? If you put monolateral fixator, is it exactly like you do circular fixator? If you do Lazarov, it's exactly like you do another ring fixators. Monolateral fixations without spanning the knee, as well as circular or ring fixators, have been most commonly used. So the question again, do they have the same function? The external fixator? No, they are different. They are totally different. Look here, this is a Lazarov and this is TSF, hexapodal, unilateral fixator, using the locking plate as an external fixator. So all of them, they don't have the same function. They behave differently. And this is the real problem when you speak about the X-fix, is exactly when you say internal fixation as one entity. You cannot differentiate between locking a plate, an ordinary plate, DCP, or axial locking plate, and something like this. The role of X-fix, it's either temporary, all of you know that temporary, with the rule, span, scan, and fix. And they put these rules, that span, scan, and fix, and don't think it's true. It's based on non-evidence-based medicine. There's no proof that you have to do span, scan, and fix, or definitive treatment. If you look to this picture, this patient has an X-fix as a temporary measure because you have comminuted fracture of the distal femur. So they put unilateral fixator, and after 10 days they remove the fixator and they put proximal distal femoral plate, and it ended up with infected non-union. Infected non-union. So it's not a rule. Now we're thinking about the definitive treatment. The role of X-fix depends upon which type of external fixator, experience of the surgeon. The third thing is teaching with no experience. I have revised many videos on the internet, people talking about the X-fix field. Many of them, they have no experience. Many of the people who teach the external fixation are doing only internal fixation. Imagine somebody is doing something and is teaching something else. So you have to think about the experience of the surgeon. He's doing that or not, and which type of external fixation. Don't mix it up. معظم الناس اللي بيعلموا الاكسترنال فيكسيشن لما تشوف في الفيديوهات اللي موجوده ما بيشتغلوش اكسترنال فيكسيشن، هم بيشتغلوا انترنال فيكسيشن. ده المشكله الكبيره جدا. The role of external fixation. عشان تتعلم external fixation, there is no shortcuts. If you want to learn this job, we don't have shortcuts.